We've developed a platform that enables our healthcare workers, right, whether that's a medical assistant, a nurse practitioner, or an EMT, to be able to do eye screenings anywhere. So that could be in the office, in the clinic, or in the convenience of the patient's home.
Welcome to Startup Health TV, where we celebrate the entrepreneurs and the innovators who are transforming health. I'm Logan Plaster, on the floor of the American Diabetes Association annual conference with Michael Leung, CEO and co-founder of Spect. Michael, great to see you.
Thank you for having me, Logan.
It was very exciting to see you last night as a finalist in the Innovation Challenge here at the ADA. Big honor. So I got to see your pitch, but give us kind of an overview. What is it about Spect that you think got you to that stage?
Yeah, so the Innovation Challenge is the ability for the ADA to highlight about 5 companies out of an applicant pool of 50 to really showcase their innovations that they've been working on. And so Spect, we're working on Eyecare everywhere. So we've developed a platform that enables our healthcare workers, right, whether that's a medical assistant, a nurse practitioner, or an EMT, to be able to do eye screenings anywhere. So that could be in the office, in the clinic, or in the convenience of the patient's home.
So why are eye screens so important, and kind of what is the current standard of care for eye screens?
Yeah, great question. So unfortunately, diabetic eye disease is the leading cause of blindness in our working age adult population today. And so the annual eye screening is the recommendation and the standard of care. Unfortunately, less than 30% of patients with diabetes actually go and get that care done because of barriers to entry, access to the specialists. And so by relocating this procedure from the ophthalmologist clinic into primary care, we hope that we're able to increase that, closer to a 70-80% completion rate, in line with other screening programs when you think about, breast cancer screening or colon cancer screening program.
So help me understand, how many people are actually potentially going blind from diabetic, retinopathy, because they're not getting their annual eye screen?
It's a matter of when and not if, right? And so people with diabetes will all develop diabetic retinopathy. With good care and monitoring and treatment, you can delay the onset, 20, 30, maybe even 50 years. But with poor control, then the onset of diabetic retinopathy can rob you of your vision in as low as 5 to 10 years.
Okay, so my understanding is you've developed both a device and a platform. So first, the device. What is it that makes it special?
Yeah, so we both have a device and a platform. The device, we refer to it as the stethoscope of the eye. And so just like a stethoscope, it's something that's very small, portable, but more importantly, easy to use, right? Again, going back to that earlier comment where it can be used by our primary care doctors, medical assistants, EMTs. And then the platform, that's the other piece of the solution for our primary care doctors. They really don't know what they're looking for, what is a healthy or unhealthy eye. And so the platform is there to support them, to guide them through the procedure in capturing the images, and then afterwards to get the images graded. So we have our team of ophthalmologists who will do the interpretation and send the results back to the primary care doctor.
Now, one of the questions during the Innovation Challenge was around the use of AI and how there are some eye scan startups that are, you scan the eye and then AI gives you a response as to whether it has this disease or that disease. But you went down the road of sending the scans to an ophthalmologist using telemedicine. So tell us about that decision.
Yeah, great question. So yes, there are, I think, 2 or 3 companies today now that are approved for AI for use in diabetic retinopathy. Unfortunately, the FDA has given pretty restrictive limitations on what they're able to do. And so what they're able to do is to say yes or no for diabetic retinopathy, and that's about it. While when we send it to human ophthalmologists, they fall under practice of medicine, and they're able to diagnose anything that they see, including cataracts, glaucoma, age-related macular degeneration, retinal detachments. And that's been really one of the biggest shockers for us, is that in our patient population, we are looking at Medicare, Medicaid patients, and so they are, above the age of 50 and older. We are referring about 40% of our patients for vision-threatening diseases, 15% of them with diabetic retinopathy, but 25% of them with something else, right? And had we done it using AI, those 25% would have shown up negative for diabetic retinopathy and just been sent home, whereas that's not the correct answer for those patients.
You're making me think of a lot of conversations I've had around the fatigue of point solutions. So the idea that, okay, this AI does one thing, so now I have to have 30 AI platforms to do 30 things, whereas you bring in a skilled ophthalmologist and all of a sudden it is it's the first step towards a continuum of care for the eye. So that makes a big difference. I want to ask you about how this changes quality of life for providers, because there's so much burnout. Primary care physicians struggle. I'll bet ophthalmologists are struggling as well. The kind of care providers that might be using this device. How do you think this changes clinical life for the primary care doctor and the ophthalmologist?
Yeah, so this is really a solution that benefits everyone, right? This is for the primary care doctors. Today they are begging and asking their patients to go and get their eyes screened at the ophthalmologist. Now they're able to bring this, care in home, take control of it, and it's an additional revenue stream for them as well. And then when you think about our ophthalmologist, they don't want to be doing screenings, they want to be doing treatment, right? That's what they were trained to do, and that's really what we should be using them for. And so by removing these lower value patients and replacing them with patients that have vision threatening diseases, then our ophthalmologists can focus on treatment.
Okay. My understanding is that you've got some news coming out soon. You got a press release that we should be looking forward to. Can you give us a preview?
Yeah, so we're announcing our partnership. We're really excited to announce our partnership with DOCO. It's an at-home mobile health company. They've been using their team of paramedics and EMTs to do home visits, to visit patients' home and do gap closures. Part of that gap closure is a diabetic eye exam. We've been working with them for 2 years now and are excited to make this official.
And your traction to date, I understand you're working with Hopkins. What does that look like?
Yeah, so with Johns Hopkins, we're working with their system of FGHCs, and so we're deployed in about 20 clinics across rural Maryland. Again, these are harder to reach populations, right? Medicare, Medicaid populations that in many cases haven't seen ophthalmologists or eye doctors in the last 10 years.
Okay. Last question. You've been a part of Startup Health since generally?
So we've been part of Startup Health, I think, 3 years now, and it's been a great partnership. We get invited to conferences, and it's always a good time to meet other companies.
Nice. Well, congratulations on the Innovation Challenge, being the top 5 out of, you said, 50 plus companies, and it's exciting that you're rolling this out with, what was the name of the organization?
With DOCO.
With DOCO, and your work with Hopkins is very exciting. So we'll be watching over the next year to see what you do.
Perfect. Thank you very much.